So we'll move on to our next speaker, Dr. Gulsanjit Singh. He will be illuminating us on the management of recurrent varicose veins. Over to you, sir.
Good morning. I'm thankful to Dr. Mukherjee and Dr. Jayanto for giving me opportunity to speak on the management of recurrent varicose veins. The definition of the recurrent varicose vein is the presence of varicose veins in a lower limb previously operated on for varices. There are few terms related with the recurrent varicose veins. The recurrent varices is reappearance of the varicose veins in an area previously treated successfully. Then there is residual varices or the varicose veins remaining after treatment. And the private is presence of varices after intervention. This includes both residual as well as recurrent. But there is a difficulty to differentiate recurrent varices from residual varices because we need a complete preoperative duplex ultrasound scanning findings and or complete operative report, which most of the time is not available with the patient because patient has been operated and the notes are not well written by the treating doctors. The causes of the recurrence: the inadequate initial procedures, only SF ligation and no stripping is done in the periphery with the earlier patient which have been operated. Most of the places they do SF ligation with perforator ligations. A neovascularization, the new veins appearing in the granulation tissue connecting the end of the ligated saphenofemoral junction. Then is the recanalization, which is there after thermal or chemical ablations. Then the new source of reflux can be accessory long saphenous vein or accessory short saphenous vein. And the last cause can be the deep venous disease, which is also a common cause associated. The factors of the recurrence from inadequate or incomplete initial treatment. It can be a tactile error, which is a failure to adequately identify the initial pathology. Because sometimes we are not doing the adequate duplex. The surgeon, if he himself does the duplex, then he can identify the initial pathology very well, and the error of tactile error can be decreased. The other is the technical error, which is failure to carry out technically adequate primary treatment. Then the recurrence is from the progression of the varicose disease itself, which can be clinical observations suggest a list of factors may accelerate the process of varicose vein disease. Is angiogenesis stimulated by surgery invasiveness, and what may trigger it in some patients only? We are not very sure about the angiogenesis, why it occurs in some patients only. Then is the incomplete thermal ablations. There are various definitions of the outcome of the treatment of varicose veins. Some treat it as sonographic absence of the target vein, no flow in the treated segment, the absence of visible reflux, the segmental patency less than 5 centimeter without reflux, and the resolution of symptoms. So this is the variable which are there in the end of the treatment. The incomplete thermal ablations. The identification of incomplete thermal ablation is dependent on the sensitivity of the ultrasound equipment used for postoperative examination, the expertise of the sonographer, and the vigor and independence with which the examination is conducted in the postoperative. The main question today is what is the recurrence frequency with the endovascular technique like laser or radio frequency, because this is being used nowadays, and what is the recurrence frequency with the sclerotherapy. There is another term, does repermeation correspond to the varicose recurrence, because most of the time it is not the recurrence but the repermeation, and stripping is nowadays less and less being used. The diagnosis: of the recurrent varicose veins, the clinical diagnosis remains essential, but does not allow a precise assessment of the private. The recommendation Euro guidelines say that we strongly recommend duplex ultrasound in patients with recurrent varicose veins after previous treatment. The different venous networks must be investigated. The investigation of the superficial venous network and the perforating veins, which is very important, is after surgical treatment, because most of the recurrent varicose vein patients which are coming are after surgical treatment, which is still being done in the peripheries and the other hospitals. So we have to focus on the saphenous vein junctions, SFJ and SPJ. We have to focus on the tracks of the stripped saphenous trunks. We should look for the sites of the previous perforator ligation in detail. So if we look for all these areas, then we can know what is the cause of the recurrence. So this is a duplex ultrasound of SFJ. If there is no residual segment of GSV, not any incompetent superficial vein in the groin, and GSV terminal valve is no longer visible, that means no recurrence. But neovascularization, the presence of multiple new small tortuous veins in anatomical proximity to the previous intervention. So we have to look for this neovascularization in the scar area in the inguinal region. With time, these veins may establish a connection between common femoral vein and superficial tributaries, lymph node varicose network, the residual saphenous trunk, which is not stripped intentionally by some or is left unintentionally. Other veins present in the saphenous compartment after stripping, like anterior accessory saphenous or posterior accessory saphenous vein. The residual stump, if it is a low ligation stump, the terminal valve is visible, as well as some radial SF tributaries like epigastric, and as Dr. Raul showed, that there can be a cause of the recurrence, and the refluxing stump can connect with anterior accessory saphenous vein or with other veins, residual GSV segment, tributaries in the saphenous compartment, or posterior accessory saphenous vein. So this can be a cause of the recurrence. So this is showing a GSV stump after the SF ligation, and this is a dilated GSV seen after recurrence which has been left. The duplex ultrasound for recurrent varicose veins after surgery is more complex. The neovascularization seems to be much less frequent with endovenous ablations, but we need a longer follow-up to conclude. Anyway, the key of the success treatment in the varicose vein is thorough mapping. A thorough mapping after recurrent vein surgery as well as for the primary treatment as well. We can use one of these methods, RF ablation, laser ablation, or foam sclerotherapy for dealing with the recurrent varicose veins. Then is the recanalized veins. The recanalized saphenous veins after thermal, chemical, or mechanico-chemical ablations are challenging to treat. Though their recurrence rate is very low, but if it occurs, they are very challenging to treat. The small lumen diameter veins which we come across need not to be treated. If symptomatic, treatment is very challenging because of the scarring in the lumen of the main vein, GSV or SSV. A widely patent vein has to be treated with or can be treated with one of the thermal method, laser or RFA, but we possibly need high energy due to thickened vein wall of the previous ablation. If the vein does not accept a catheter because of the adhesions, the chemical ablation is done. In practices, advantages of the foam sclerotherapy. Foam sclerotherapy is the only technique that can deal with almost all types of the recurrent veins. Foam spreads into the network of the varicose veins through large and tiny communications, sometimes which are not detected by ultrasound also. The truncal recanalizations can easily be treated with foam sclerotherapy. With echography, we control the procedure. Foam is easily visible. Spasm of the vein is easily visible and good sign of efficacy. And foam sclerotherapy, as you know, is less expensive and is an aggressive technique. The European guidelines recommendations are we recommend sclerotherapy for residual and recurrent varicose veins after previous interventions, grade 1B evidence, GSV or SSV truncal recanalization, the retreatment by closing partially recanalized vein segments during the follow-up is recommended, again grade 1B evidence, and this improves the results. To conclude, the recurrent varices or private occur whatever the initial technique of treatment is there. So there is a general agreement that ultrasound guided foam sclerotherapy is the first line of treatment in almost all the cases of the recurrent varicose veins. Key to success treatment is thorough mapping. The thorough duplex ultrasound scanning at the before treatment is most important. Unless one is committed to careful follow-up and adjunctive treatment, the practitioner and the patient will be left with unsatisfactory results. No redo surgery at the former SFG or SPJ in the patient which have been previously operated surgically. The other techniques like phlebectomies, EBL, pelvic embolizations are used in specific cases. Thank you.